ISNTD for inviting me to speak and for choosing such a great venue, very convenient for Imperial College people also to attend. I feel a bit like a magician sort of at the beginning of his show, and he's already got the rabbit in one hand and the hat in the other, because a lot of what I've said echoes very much with what's been presented already this morning. But I just thought I'd tell you a little bit about some work that I'm involved in currently, which is sort of thinking about the end game for schistosomiasis and the role of WASH as we start to think about elimination of schistosomiasis as a public health concern, and we're still a long way from that, but that's what we're starting to discuss internationally. And specifically focusing in on some research I'm involved in looking at the water side of WASH for schisto. So I'm a public health engineer like Barbara. I'm a WASH nerd, I guess, is what she called my kind of person. I wear that with the badge of pride, I'd say. But a lot of the work that I do is very interdisciplinary. So I'm presenting this a bit with an engineer's hat on, but hopefully also you'll see that the importance of some of the other interdisciplinary contributions to this problem also. And I've titled it WISER, Water Infrastructure for Schistosomiasis-Endemic Regions, and my subtitle is a new acronym maybe to challenge WASH for schisto specifically. So what do we mean when we say WASH for schisto? There's a lot of advice out there and guidance and web pages which say WASH is going to be critical for achieving elimination of schisto, but and maybe part of that is a bit vague because sometimes it's people who are saying that who maybe come from the medical or the drug side of things, where when you say drugs are important for schisto, everybody knows that you mean praziquantel probably is the drug you're talking about. But WASH, of course, is not just one solution. It's a whole range of different potential interventions under that heading of WASH. And it's not always clear what the best intervention is going to be in schisto-endemic regions. And I think I like to give my take-home messages up front in case you doze off halfway through the presentation. So the first take-home message, I think, is that the WASH for schisto is not going to be the same as the WASH for fecal oral diseases. And if we're talking to people in the WASH sector, that's something that is not always self-evident. It's something that we need to emphasize. The schisto, the life cycle of the disease is completely different, and we need different prevention. Sanitation and hygiene, of course, are very important for many reasons, and they have a lot of benefits which go beyond health, as we've already heard today. But I'm going to show some evidence and sort of thinking about the theory of the life cycle that suggests that really, unless you get universal coverage and usage of sanitation and hygiene, which you might achieve in the long run, but probably not any time in the short run, the impact on schisto specifically is really minimal. The link to preventing fecal oral diseases is a bit more of a linear relationship, I would say, in terms of, not quite linear, but it's a bit more one-to-one in terms of the coverage level of sanitation and the resulting impact on fecal oral diseases. With schistosomiasis, it's definitely not a one-to-one kind of situation between coverage and disease prevalence. And so really, if I was a person living in a schisto-endemic region and I had to choose really what the WASH intervention was to prevent or to reduce the likelihood of infection with schisto, I would actually focus more on reducing contact with the infested water as being more important, especially in the near term, until sanitation coverage increases. And as I say, that sort of makes complete sense based on the life cycle, and Barbara already made the case really strongly this morning that we have to think about how these diseases are spread when we decide what are the best sort of WASH interventions. And Anouk showed a similar sort of diagram. This one's from the CDC, which I've stolen. But you can see that, again, the life cycle, it goes from eggs to snails to the snails hatching a cercari, which are then coming in contact with people and causing infection. And so if we put sanitation in there, it would sort of be on the right-hand side of that diagram and blocking the eggs from getting into water and hatching into Myricidia and infecting snails. And if we put water supply, that would be in the sort of top left of that diagram, preventing the cercari, which are already in the water, from coming in contact with people. The problem, though, which is maybe something which is not fully understood or not emphasized enough, is that, and Anouk made this point already today, is that really just one of these Myricidia results, some papers have said, up to sort of 20,000 cercari being shed from a snail. So practically speaking, if you're relating sanitation coverage to how many cercaria are in the water, it's almost the same. If you had a community of 1,000 people and one person was not using the toilet and the other 999 were, it's almost the same as if nobody had a toilet. So it's definitely not a one-to-one sort of relationship there. Again, that's not to say sanitation is not important and we shouldn't be implementing sanitation in these regions. It's just saying for schisto, unless you have very close to universal coverage, including in adjacent endemic regions where somebody might be infected and come to your region, really it's going to be more about reducing water exposure, assuming that the water is exposed, and just coming up with solutions to reduce exposure to that contaminated water. So how do we reduce contact with infested water? It sounds like a simple thing to say, but of course people need to have contact with water for various reasons. And one solution would be to provide an alternative safe water supply. But that water supply would have to be not just for drinking water, but also for all of their other water needs. So washing, recreational use of water, for example. Okay, so again, that's something where people in the WASH sector typically focus on drinking water provision, not necessarily these other forms of water use in a community. Also, reducing water contact doesn't necessarily mean just providing a safe water supply. So even if we did implement a water supply that could provide all of the water needs for a community, if you still had fishermen or children swimming in a contaminated river, even though they had clean tap water, they're still going to be at risk of infection. Also, of course, mollusciciding is another thing that might play a role here. But again, I sort of think of mollusciciding a bit like sanitation, in that unless you can sort of guarantee me that you're getting almost 100% of the snails out of your environment, I'm a bit skeptical in terms of that life cycle of whether the risk is going to be reduced significantly. And it was a great talk about the impact of acting for health there this morning, and communication of the risk of water contact is going to be key in any of these kinds of interventions. So it's not just about providing infrastructure, it's also about making sure that people understand what are the risks of water contact, and also how to go about sort of maintaining and sustaining that infrastructure over time. So I thought I'd just very briefly summarize some of the research that we've been involved in recently with WASH and Schisto, and then tell you a bit about this WISER project that has kicked off recently. I supervise a PhD student, Jack Grimes. You may have met Jack over the past few years. I think he presented at this conference last year, a couple of years ago. Jack's PhD sort of had two parts. The first was to conduct a systematic review and meta-analysis of all the studies out there in terms of the impact of water sanitation and schistosomiasis. And we also published a slightly more qualitative review, which wasn't sort of numerical in terms of calculating odds ratios, but discussed some of the other types of studies which were a bit more observational and descriptive. And then the other part of Jack's study was a huge national mapping program, which we were able to collaborate on in Ethiopia, which was looking at statistical links between school water sanitation and hygiene and schisto and STHs. And to save you from having to read a ton of papers, just a few sort of key take-home messages from those studies is that there's been a lot of research done on the link between WASH and schisto, but a lot of them have very serious limitations, which mean the conclusions from them are a bit difficult to rely on. So one example of that, which is maybe specifically relevant to our discussion today, is the fact that a lot of these studies haven't really given a very good description of WASH. So they might have said, yes, those people had a toilet, yes, those people had access to water, or they didn't, but not really any more detail. And really the devil is in the detail in terms of the impact on schisto. So that was sort of, I guess, the most important conclusion I would say from a lot of the reviews was just that there was a lot of limitations of the previous studies. And then from the mapping study, which was done with SCI and also Partnerships for Child Development and the Ethiopian Public Health Institute, this was a very large study. About 80,000 kids were involved in it. It involved, again, collection of intestinal schistosomiasis health information, and also infection with hookworm, roundworm, and whipworm. And our contribution to that, our sort of innovation, I guess, which we brought to this was we really tried to characterize the WASH a lot better than had been done in previous studies. So we developed these WASH scores, which we used to rigorously really quantify the description of the WASH facilities that were available. And then we looked at how you would statistically link that kind of a WASH score to your likelihood of being infected with intestinal schistosomiasis and STHs. So, for example, the water score counted how many times a child goes to collect water every day, what is the source of the water, how that source varies seasonally, because quite often, they go one place in the dry season, another place in the wet season. And similarly, scores for sanitation and hygiene. So the innovation, I think, was really in the statistical handling of this data. And we use this statistic called Kendall's tau, which is a way of sort of creating rank orders. So instead of sort of just comparing the score against a health metric, it was about ranking the toilets based on their quality, or the water supply based on their quality, and using this Kendall's tau variable to relate to your likelihood of having some of these diseases. And so for S. mansoni, the strongest association was with water contact, which again made sense to us, I think, based on what I've discussed already. And we didn't find a significant association with sanitation. And part of it may be what I discussed already about this link, this important part of the snail in the whole process. But there are probably a lot of other explanations also. One, for example, would be just because you don't have a toilet doesn't necessarily mean that you're defecating or urinating into a fresh water body. Maybe you're going somewhere else. So the link with sanitation is a lot trickier to nail down. But there was definitely a strong association with water contact. So focusing on water contact, if you're a WASH organization going into a community in a schistoendemic region, probably the first thing to do is not to think about treating the water, but just looking, are there safe alternative supplies? So protected groundwater, or maybe is rainwater harvesting possible with adequate capacity to support all of the water needs, not just the drinking water needs of the community. If not, then maybe we have to think about abstracting, so taking out water from the environment and treating that water somehow to provide a safe supply. And Alan mentioned that there was a lot of work done on how to treat water and the impacts of WASH sort of going back several decades, but actually there are some big gaps in the knowledge still about how exactly you should treat water to kill or remove these cercari which infect people. And also some of the variables that are important to consider as you implement these water treatment processes. Again, I'm a WASH nerd, but I recognize that for both of these technical options, you'd have to accompany that with also some type of an intervention to reduce occupational exposure and recreational exposure. So there's a great study in Ghana not so long ago which showed that just putting in a chlorinated swimming pool for, I think it was in a boys' school, to swim in the pool instead of going to the river actually had a huge measurable impact on the likelihood of schisto infection. And if somebody's out there in the audience, a funder looking to write a big check, I personally think a great way to fund an intervention would be to just buy a lot of boots and gloves for fishermen, actually, and do sort of a bit of a risk communication study with people who are occupationally exposed. And that could go a long way to helping the problem. Also, it would have to be accompanied by awareness campaigns about the risk of exposure to contaminated water, of course. Some of that might involve some of these behavior change and sort of acting solutions that we heard about this morning. And you also have to have some sort of really concrete plans in place to ensure that whatever the solution is, the community's been involved from day one and that they're on board in terms of the uptake and maintenance. And this is quite often where WASH interventions and infrastructure goes wrong in development. But it's something that we have to try to improve on and ensure that that's going to be in place for these communities. So some of the knowledge gaps, and we'll discuss this a bit more in the workshop this afternoon, but for those of you who are maybe water treatment people out there, we don't, for example, I couldn't even tell you right now what a chlorine dose and contact time you'd need to add to water to make sure that it was completely safe from cercari. There's a little bit of data out there for mansoni. There's not very much data for hematobium. Most of the data is in very clean waters under very ideal lab conditions, but not actually real waters. Similarly, how do you safely design a sand filter to treat water for schistoendemic regions? And some other things there. Even if you just stored the water for a while, because the cercari die within sort of 48 to 72 hours if they don't find a human host. So maybe the simplest solution would be to come up with ways of designing storage tanks for these communities to sort of treat the water in a non-chemical, very low-cost kind of way. I think James this morning mentioned an interesting point that there's a lot of research on WASH and an individual disease, but quite often in a lot of these countries, people are exposed to and infected with many different types of diseases. And so when we think about drinking water treatment, historically, we look at sort of surrogate organisms, and we say as long as we can guarantee that the water is safe from that surrogate organism's perspective, we can therefore guarantee that the water is safe for all the other pathogens that might be in the water. And I think there is a bit of a need for us to consider that kind of approach with NTDs also. So if water is free from fecal oral pathogens, and the WHO has lots of guidance about how to achieve that, does that necessarily mean that it's also free from infective cercari? If the answer to that is yes, then that's actually really good, because it makes it a lot simpler to communicate to WASH people how they have to go about designing water supply systems, because it's something that they're already familiar with. If the answer to that is no, then it's a bit more of a complex process. Another big part of it, I think, that WASH people can contribute is not just designing solutions, but also coming up with better ways of assessing the risk of contamination or the risk of exposure. So it's not just about treatment technologies, it's maybe also about monitoring and sensing technologies. And part of the research we're involved with currently involves people with backgrounds in synthetic biology. Also, the Natural History Museum are partners who do a lot of research into environmental DNA. And maybe we can develop some techniques which really allow us to get a better sense of what the contamination levels are of water bodies. Ideally, we'd like to be able to do that very rapidly and cheaply and in the field. Because a lot of countries now are starting to talk about, well, when can we actually stop doing drug treatment for schisto? Can we start to talk about a time when we can scale back the drugs? And personally, I wouldn't feel comfortable ever doing that unless I had a good way of sort of monitoring what was the environmental level of the cercari in the communities. Because if you scale back the drugs, people are going to get reinfected if that risk is still there. And then finally, the sort of non-engineering-y, nerdy side of things would be, how do we sustainably implement and maintain these solutions in communities? Of course, Barbara made the great point, it's really bad engineering if you don't consider these things. So it's part of the engineering discipline, I think, to consider these things. But very important to also consider things like cultural barriers and what are the sort of planning structures that need to be in place, financial, educational, maybe health behavior interventions which have to be in place to ensure that these solutions are sustainable. So this WISER project is recently started. I'd encourage you to visit our WISI webpage, which is wiserschisto.com. Very easy to remember URL. And just a few details about the project, and we'll discuss this a bit more maybe in the workshop this afternoon. It's funded by the Engineering and Physical Sciences Research Council. So the research councils in the UK currently have a big pot of money for global challenges research. So it came through a grant funded through that program. 3-year project, very interdisciplinary. There's some photos of some of the people involved. Alex, Laura, and Lucinda are actually in the audience, so you can also ask them about it. The last thing I wanted to say is we're going to have a number of workshops in Ethiopia and Tanzania over the next 3 years, and we'd really like to involve as many stakeholders as possible in that. So if you'd like to participate, please do contact me. It really is about interdisciplinary work together to see how we can get these WASH solutions sort of implemented. Okay, that's all I had to say. Thank you.